Dr. Daver, what does triplet therapy in AML mean for the future?
So when we say triplet, what we're really thinking about is building on the existing FDA-approved combination of HMA venetoclax. So as a background, AZA venetoclax showed a CR/CRI, which is a complete remission rate of about 70-75%, with a median survival in 15 months. This was in older patients above 75 years of age, those who are not considered fit for intensive chemotherapy. Although this was a major step forward in comparison to what we have seen with traditional low-intensity therapies like azacitidine, decitabine alone, we do see the 3-year survival is about 25 to 30%. So this is a progress compared to 10% long-term survival we used to get a decade ago. But of course, we want to improve on that. Also, molecular analysis of data has shown that there are certain molecular subsets that don't respond as well to azacitidine venetoclax, or if they respond, they relapse quickly. These include the FLT3 mutated and the TP53 mutated, as well as potentially MLL rearranged. And so here we have started incorporating the targeted therapies like FLT3 inhibitors, like the menin inhibitors, like CD47 antibodies to target those specific high risk or bad actor molecular cytogenetic groups. And we are seeing that with the combinations of these 3 drugs, especially for those particular molecular subsets. So azacitidine venetoclax FLT3 inhibitor for FLT3 mutated, azacitidine venetoclax magrolimab for TP53 mutated, the response rates that we're getting, as well as the depth of response and the early trends towards survival are looking very, very promising compared to what we have seen with azacitidine venetoclax alone. So we believe, and I personally believe, that these 3 drug combinations, the so-called triplets, will actually be eventually the way to go forward. Now, that being said, one has to realize that when you add a 3rd drug, there is a cumulative myelosuppression. Azacitidine venetoclax is already a myelosuppressive regimen. Yes, it's manageable, but it is myelosuppressive. And with the 3rd drug, this can become more cumulative. So we have been working for the last 34 years and continue to work on dose optimization, because since we are seeing true synergy, both preclinically and what we think in the clinic, we are not needing to give full doses, and we're doing reduced durations of venetoclax and doses of the FLT3 inhibitor. And now we feel that some of these triplets are actually giving very, very, very good efficacy. There's a lot of discussion in the community about whether we need to combine all 3 drugs up front, or can we sequence these drugs, or can we introduce a targeted therapy based on a molecular escape. And I think a lot of these will have to be evaluated, and many of these are being looked at in various trials. But I do think the bottom line is that bringing in your targeted therapy or immunotherapies early on in the frontline setting in some way or the other is probably where you're going to get the most bang for the buck and the most benefit in curing patients long-term, rather than trying to reserve them for the salvage, because in salvage AML, historically, nothing has really been able to improve the long-term cure rate significantly. So the activation tip for this question is that now with the identification of certain molecular subsets that have poor outcomes with the HMA venetoclax, we have started incorporating targeted immunotherapies in the earlier settings, either upfront in the 3-drug combination or an early sequential approach. And we believe that with such combinations, we may be able to achieve deeper remissions and longer responses. Some of the early data with the FLT3 inhibitor as well as the CD47 antibody triplets are showing very, very promising activity and are now moving into larger multi-center and randomized studies.